Okay, members, as we all know, LDH is a significant portion of our budget, and this will not be the last time we see them. So just for the purpose of today's meeting, and as we move forward, what we're going to ask Heather to do is go through the high points of the presentation, which I don't know, how many slides do you have roughly?
159.
159 slides. So if you want her to go through slide by slide, you can work with her afterward on this, in your office, all 159 slides. What I think is a more realistic thing to do is ask Heather to go through and hit the high points that we would like to focus on. And then knowing very clearly that we are going to be back here dealing with LDH in many different sections. Specifically, obviously, the hospital funding formula is a big deal that we have to work through, and we're really not in a position to even discuss it. So we can, again, bring up the hypotheticals of it, but I don't know whether that would accomplish much. But that could really have its own meaning in and of itself, the importance of that. So I think as we move forward, I think that's going to be the strategy as it works for LDH. I do think it's important for members when you leave here today, assuming we don't do all 159 slides, it'll be at a reasonable time, to take the portion of your binder that deals with LDH, take it home and go over all 159 slides, mark it up, have your questions so that as we meet them, as they continue to come before us, we have a better understanding of what's in front of us, and you can ask better questions. Because this is over half our budget, and we know we're going to have an endless amount of questions, but we've just got to put them in an order where we can, make the best decisions for all of our hospitals and all of our constituents back home. So with that, Heather, if you just want to kind of hit the high points, and members, we still want you to ask questions. It's just we're going to try to move through a little bit easier than we would normally do to kind of get this rolling. Again, all 159 slides will be available to you. So thank you. Yes, ma'am, when you're ready.
Yes, and as Senator Henry said, I'm going to go through it. It'll probably be a little bit quicker. I'm going to try to highlight the major changes in the agencies, but there's lots of information that I provide. So that way you have it here. There's every single adjustment that was done in the executive budget for all 19 agencies in LDH. It's all there as a reference. If you have questions, I'm available, the department's available, but we're just going to kind of run through. And if I'm going too fast, you want me to slow down on one, just let me know and I will. And go back if there's something that jumps off the page that you want to ask questions about or have me elaborate on a little bit more. So we're going to go ahead and get started with LDH. And there's also a table of contents for you. So as you're looking for a specific agency, it's all laid out there for you. So basically, as I'm sure y'all are well aware, LDH is that primary entity in state government that's responsible for the health and well-being of Louisiana citizens. There are 19 agencies in LDH to provide services for your mentally ill, persons with developmental adult onset disabilities, the elderly, those with addictive disorders. Your public health office is in LDH, and the Medicaid program is under LDH. And this is a slide that shows you the core units within the Department of Health that answer to the Secretary. Aging adult services, behavioral health, developmental disabilities, public health, LEARN, and your Medicaid program. LDH also has 11 agencies that answer to boards. Those are your 10 human services authorities and districts that are scattered throughout the state and the Developmental Disabilities Council. So now we'll go start through the budget. Here's a broad overview of the department since FY15. You've seen this budget has grown. Your Medicaid program is your driver. It's also a driver of the means of financing. If you look at the very bottom of the page, that realized funding for the Medicaid program, that shows you that I took all the state funds that were actually budgeted or paid in the Medicaid program and what was state portion and what was federal portion. We have tons of match rates in Medicaid, so it doesn't quite always work out some of the main ones we talk about, but this shows you what we realized in those years. And you'll see how federal funds have gone up around 21 to 77.29, in FY22, 77.37, and notice how large that tan color of federal funds grew. So Medicaid really is your driver in this department. We've also did the ACA expansion falls in here, so that's a large portion of your growth. We've added a new program for your managed care incentive program, that's almost $500 million. And then COVID. We've enrolled a lot of people under the maintenance of effort requirement in COVID, and that grows your program because they're enrolling in Medicaid. I get asked a lot of times how much LDH is of the state budget. So this shows you, if you look at the general fund, the top darker blue is the growth in the general fund for the entire state from FY15 to FY23, and the bottom is LDH. So you notice they kind of track that same amount, but it shows you what those percentages are and what that movement is for each year. And at the very bottom, you'll see LDH as a part of the state, what those percentages are. So with recommended budget, LDH is consuming about 26% of the state general fund in the recommended budget. And I have this for all the means of financing. For FY23, it's about 22% for the interagency transfers. Fees and self-generated, it's about 12.65%, looking at that bottom percentage. Fees and self-generated has grown at a higher rate in LDH than it did for the state at 203%. A lot of that has to do with intergovernmental transfers in the Medicaid program. Statutory dedications, you've seen that that's also grown as well, and the stat deds in LDH consume about 22.5% of the overall state. Keeping in mind that you have provider fees and the premium assessments on the managed care programs, that's your largest statutory dedication in the department. And then federal funds. Federal funds have greatly grown for both the state and the state overall, as well as LDH. That's growth in Medicaid and also a lot of your COVID money. And then LDH also gets a portion of some of the hurricane financing for their response. But for 23, you notice LDH is about 64% of the federal funding coming into the state is flowing into the Department of Health. So it's a large portion of your state budget. And then this last slide shows you just of the total budget. So for FY23, it's about 41% of what's recommended. So that's a large portion of the budget that's before you this upcoming session. This is a reference, just so you'll have it. For all of those years, we showed you the means of financing. This is the breakdown of how that works for each agency, those actual expenditures. Again, you'll notice that Medicaid is such a large portion of it. The next would be Medicaid administration, and then your Office of Behavioral Health. You'll also notice a little further down the page the growth in recent years in OPH. A lot of your COVID funding is flowing through the Office of Public Health. And the bottom one kind of shows you the enrollment trend. I thought that since we're putting the expenditures, you can see that growth in Medicaid, it would help you on that same slide to see the growth in the Medicaid program over all those years. If you look under fiscal 22, this was the actual unduplicated count of almost 2 million people in the current year, and we're projected for enrollment to go down next year to about 1.7 with the changes in the MOE, and I'll get into that a little bit later. In the current year, if you looked at the growth, LDH has grown about $1.1 billion in their budget between what you enacted and where you're sitting today. They've had a lot of BA7s. If you'll notice in that first group in August, second from the bottom, there's almost $500 million that was added to Office of Public Health, and that was increased in GOSEP money that came in from FEMA money, went to GOSEP. The IAT was then sent to LDH, and that's for hospital staffing contracts. If you look towards the bottom of the page, the last BA7 for October, another $216 million of that is for...
Just real quick.
Mm-hmm.
Why did the GOSEP money why did the hospital staffing money go through GOSEP?
Because it's FEMA money. So all FEMA money has to come in through GOSEP, and then it got IAT'd for LDH as the health agency.
Because it's FEMA.
Yeah.
We already moved that in joint budget, didn't we?
Yes, sir. This is just explaining, in case anyone noticed, we added about $1.1 billion from when you enacted the budget in 22 to where we're sitting today. Mm-hmm. So normally we don't go into this much detail in the current year, but I wanted to have this for you as a reference, because if you're looking through this, you might say, oh my goodness, I didn't realize, because you do everything piecemeal each month, and this kind of shows you all of the actions that's happened. And like I said, we've grown LDH's budget by a little over $1 billion in the current year because of either hurricane money or FEMA money for COVID. So it's a lot, and we'll non-recur that out of next year. You'll see that adjustment a little bit later. But yeah, and we did a lot of carry forwards. Medicaid's carry forward alone is almost $300 million, that second line in August. So you also have a lot of carry forwards in the department. That will all come out of the budget for next year, but that was just some things that they're waiting on CMS approval for, so we couldn't pay it by the time the fiscal year closed. We had to carry it forward to pay it this year. So yeah, so I just wanted, said we normally don't do this much in the current year, but I wanted y'all to have that there in case you have questions as kind of a reference, so that way you could see all in 2 pages, just what all changed in LDH's budget since we passed it last spring.
Trying to catch up, you got so many numbers. Okay, so the 2.3 million state general fund dollars. just those dollars, how much federal does that draw down?
Well, there's 13 billion in federal funding, 13.8.
So that's what it draws.
Yeah, well, all of that match in there together. Because part of that is in other agencies that don't have their, that's not Medicaid, that's the entire department.
Right.
Yeah, but if you just look at all the state funding we have, kind of add that up, we know that we're drawing
Pay the
down.
1.1, the 705.
Yeah. And some of these are, like I said, the IAT that's coming from GOSEP, that really is federal funding. But it's just because it's federal funding in GOSEP, we interagency transfer it to LDH. That's how we move that money, because a lot of federal funds have a single source agency they'll send money to.
All right.
Okay, so we'll go to slide 18. Just an overview of what budget adjustments are, and just a little reminder that for this year, our freeze date's December 1st, 2021. We have all our statewide standard adjustments, and there's lots of agency-specific adjustments. This chart on 19 kind of summarizes what all the adjustments are. You'll notice that statewide standard adjustments total about a negative $301 million. Why? If you look towards the middle of the page, you'll see the non-recurring carry-forwards is $344 million. So all those carry-forward BA7s we did, those are being removed there. LDH also has a number of means of financing substitutions, adding $632 million of state general fund. Most of that is in Medicaid, and that deals with the change in the FMAP. It deals with a regular change in our match rate, the going away of the COVID match rate enhancement, as well as removal of the last of the excess stat DADs we realized because of COVID changes in our match rate. This chart shows you the means of financing of the department as recommended for FY23. You'll see that the total recommended budget is about $17.7 billion. 71% of that is federal funding. About 16% is state general fund. Then if we jump to the top smaller slide, that's medical vendor administration and payments, that's your Medicaid program. It's about $15.9 billion, or 89.9% of the total budget for the department. And you'll notice you still have 74% federal funding, because with Medicaid, the driving force is your federal funds. The federal government pays the vast majority of our expenses for our Medicaid payments program, and at least half of the cost for the administration of the program. The lower, smaller slide, that's the rest of the department altogether. So notice when you take Medicaid out of that mix, the funding mix changes. The federal grants are about 47%. You have a higher percentage of state general fund, interagency transfers of the Medicaid payments to all these agencies. And the rest of the department, all those other 17 agencies are only about 10% of their budget, because Medicaid is such a large portion and kind of skews that spend across the entire department.
What did you say that number was, or we have on Medicaid? What's that number?
Medicaid's 89.9% of the total budget of the department, and it's 15.9%, almost 15.9%, $50.9 billion. So you're almost looking at $16 billion for the Medicaid program,
Right.
admin and payments.
How many patients? I mean, how many participants?
For next year, they're estimating 1.8 million enrollees. Currently, today, we have almost 2 million.
So I thought it's almost 50% of our population, right?
Mm-hmm.
Why is the drop?
Because we're assuming that the public health emergency will end. Right now, it's scheduled to go through April. When the public health emergency ends, the maintenance of effort requirement on the Medicaid program for eligibility will cease, tied to the enhanced match rate for COVID. So once that public health emergency ends, the department will be able to begin redetermining eligibility and removing people from the rolls. Currently, no one can be removed from the Medicaid rolls unless they contact the department and voluntarily get out, they pass, or they move out of state.
Okay.
This is just for a reference for you, since the other slide showed the pie chart. This breaks down the means of financing for each agency. The major sources of funding, as I mentioned earlier, you have a lot of IAT going from Medicaid to individual agencies with an LDH. They actually provide Medicaid services. Your fees and self-generated are your intergovernmental transfers. That's matched in the Medicaid program. And then your regulatory fees in agencies like public health. We'll go over stat DEDs in a minute. And the major source of federal funding is going to be your federal participation in the Medicaid program. And then we do have federal grants in OBH and OPH for your behavioral health and your public health services. So you'll see here, we're going to start going through the dedicated funds. About the middle of the page, when I mentioned earlier about the provider fees and the premium assessments on the managed care plans, that's your largest stat dead. It's about $800 million. So that's used as match in the Medicaid program that either the providers pay the state or there's an assessment on all insurance premiums, but for the assessments on the insurance premiums for the Medicaid managed care programs, that just rolls into Medicaid to use that as match there rather than flow into the general fund. I want to point out on this page there are two fees. The second, Oyster Sanitation Fund, and the last one, Vital Records Conversion Fund. Both of these funds were repealed because these are really fees. So beginning in FY23, those fees will now show up as fees and self-generated revenues and no longer statutory dedications. The fees will still be there. It's just how we account for them. That was one of the recommendations of the subcommittee of budget committee that is studying statutory dedications, recommended it. So Act 114 of the 2021 legislative session repealed those two fees, and those monies will now flow as fees and self-generated into LDH, still to operate those programs. And this is the chart I've seen numerous times. I do want to point out that for LDH, as we're looking through expenditures, all of Medicaid is in other charges, and most of the human services authorities and districts are allowed to spend their money in other charges. So you won't see salaries, a lot of those normal breakdowns, because the human services authorities and districts have special autonomies granted to them in their authorizing legislation, and they answer to a board that's appointed and provided for in statute, and that board is allowed to spread their money in a way that best fits the parishes and the people that they're serving. This shows you the expenditures for the department. You've seen this for all the other agencies. Again, you'll notice other charges is absolutely distorted in this one because you have all of Medicaid in there as well as most of the human services authorities and districts. If you look at salaries, the recommended number for FY23, it's $386 million. Another agency would be much higher. This one, it's lower only because of Medicaid, but you still have over 6,000 employees in this department. Here's your look at positions. LDH has about 16% of the positions across the state. They also have other charges positions. Most of those in your human services authorities and districts, you normally wouldn't see a number that high. It's over
Slow down just a
1,300.
minute.
Okay.
Let us catch up. All right.
Okay.
So they have total they have 6,400.
Of authorized positions, yes, sir.
They have that many TOs authorized.
Yes, sir. Because you have 24-hour facilities as well as over 1,000 individuals, working in Medicaid administration.
All right. Good.
And this is the breakdown of salaries. You'll see that it's about $386 million, and box number 1, other compensations about 19.6, related benefits 227. Looking at total related benefits, or UAL payments are about $152 million. That's a lot in UAL. You have lots of employees that's going to be assessed on. Retiree health is roughly 53. Your remaining benefits for other things are about 69. You've got about 15.6% of your population that's eligible to retire or on drop. So you do have a large portion of this department that could turn over within the next year. This shows you where those positions are of the 6,457 spread across the department. You'll see that OCDD has the largest amount with 1,682. Most of those are either staffing Pinecrest or Central Louisiana Sports and Services Centers, the two 24-hour facilities under OCDD. Next is Office of Behavioral Health. 1,600 of their positions are for the operation of the state's mental health hospitals. And then you have about 1,200 in Office of Public Health. Those are your sanitarians. The WIC program is there, reproductive services, your public health lab. So that just kind of shows you where they all spread out across the department. This shows you where those other charges positions were. Again, LDH has more than most do, and that's, you'll notice they're all in the human services authorities and districts except for 6 in behavioral health, because all of the positions for those 10 agencies that are your districts are in other charges. They're not in authorized charges. So we track positions a little bit differently in LDH in 2 pots. And this is that second pod of the spread of those in the districts. Your non-discretionary, discretionary expenditures, about 57% of LGH's budget is discretionary, 43% is not. When you look at what is non-discretionary, about $6 billion of non-discretionary or federal mandate, and most of those are the federal mandates for Medicaid services or mandated populations. You also have your constitutional obligations, that's your UAL. Again, it's a large department. You have a large assessment of UAL on it.
Go back to the pie chart. Other discretionary, hit some of those as discretionary expenditures.
So basically, if you I'll break down next, under Medicaid, it's about $8.2 billion of what Medicaid is. This is where that breakdown is. So for Medicaid, think of it as all of your non-mandatory populations, so like your Medicaid expansion, you're under the Affordable Care Act,
Yes.
they would fall under that discretionary pot in Medicaid.
But once you've taken the Medicaid expansion, while we're in pandemic mode, you can't back out of it.
Yeah. I mean, and so this is following our traditional definitions of what is discretionary, non-discretionary. I don't know that it hasn't really been adjusted for COVID. And going forward, we're assuming that ends. So for FY23, the year we're talking about, we're assuming the public health emergency will end in April and won't continue into next fiscal year in July. So for FY23 going forward, we're assuming that public health emergency, or that what the executive budget is assuming the public health emergency has ended, so that maintenance of effort on eligibility will end. It is no longer going to be there and guide operations next year.
Okay.
So hopefully, they'll begin redetermining eligibility, and then we'll go back to more normal operations.
Is anybody turned down that applies from?
If you're not eligible, then yeah, you're turned down.
I thought right now they couldn't turn anybody down.
They have to be eligible. You still have to be eligible. Once you're eligible and you're enrolled,
Can't remove them, but
then you can't be removed even if you're no longer eligible. Because they're not redetermining eligibility. Normally, if some of y'all were there, remember, before the pandemic, they started doing the quarterly rechecks, and every year everybody has to be redetermined. So the annual redeterminations have ceased, and then they were doing quarterly checks and running and seeing who was not eligible. And so, but those had to all stop with the pandemic and accepting the 6.2%.
okay.
And this kind of shows you the slide, if you kind of track out what LDH is estimated to spend. Normally spend about 94.4% of their budget. This manner shows them a little bit less. I will say that the monthly Medicaid report that comes to Budget Committee is projecting about a $500 million surplus right now in the Medicaid program. And a lot of that is going to be your general fund, we've realized, or your state effort for the change in the match rate, and then kind of overestimating what some expenditures were.
Where's that at?
But that's going to contribute to part of why that spend is so different.
Go ahead. Mr. Milligan.
Thank you, Mr. Chairman. Can we back up to 33 for a second? I'm reading this, but I want to ask you, on the non-discretionary funding, explain to me the avoidance of a court order at $1.3 billion.
So those are expenditures that are being made so that all these various settlement agreements, we are in agreement with them. So things like forensic mental health services. We have to provide forensic mental health services. You have the Cooper-Jackson settlement, where we had a wait list for individuals that were determined either not guilty by reason of insanity, or they needed to have a determination for trial, and they were sitting in the jails. So the federal government said, you can't do that. You have to expand your services. You have to get them into mental health facilities. We got ourselves into a little bit of trouble with individuals, putting mental health individuals in nursing homes. We've had to ramp up our services for getting those individuals in a proper setting and getting them out of nursing homes. We've had issues in past with lawsuits regarding access for Olmstead, the U.S. Olmstead decision, where you have to provide care in the least restrictive setting possible. So that means that we have to provide community-based alternatives to nursing homes and ICFDDs. So we've had a number of issues over the years. The WIC program, that one's not that large, got themselves in a little bit of a situation with USDA and how it was being administered. So now we have to shift how we do that to get that, and then that was done a few years ago on the right ship. So there's just various, things that have come up over the years that services we have to provide, or we're actively, in an agreement with the federal government, with the courts, saying, hey, you've got to do this because of the way we were doing it in the past wasn't in line with what they wanted us to do.
So we're held hostage to that. Does that change? Does it go down? Does it increase? Does it stay at one point or almost 18% of our non-discretionary?
Yeah, well, every year it's going to change a little bit, but once you're released from some of these, if you go back to what you were doing before, we'll end up there again. So I would think that if, like looking at forensic patients, if we say, oh, we're released from Cooper Jackson and everything's great, then if we go back to letting, those individuals sit in jails and not get, mental health so they can either stay in trial or because they were convicted, not convicted is not the right word, I'm not a lawyer, but found not guilty by reason of insanity, we're going to be right back where we were before. Because someone will say, hey, state of Louisiana, you're not doing what you're supposed to be doing. You have to do this differently.
So there's some naive hope that I have that we might be able to reduce that number by doing things better or right or whatever the case may be, correct?
Well, you'll be spending that money, so it might not show up there, but you'll still, like those services, those individuals need to be served.
Right.
So you're still going to be paying for it. We're isolating it here because we're doing it because of this. I don't know that you could say, hey, down the line, I don't want to do this, or if they release us, it would mean that we could cut that because, like I said, we'll be right back where we were before if we're not providing those services, because that's the way that the courts in most cases say we should have been doing it from the get-go, either because of federal law or a Supreme Court decision.
But if these are considered penalties, it seems like at some point.
They're not penalties. What these is the federal government coming in and saying, hey, this is how we believe you're Louisiana, you're not doing it right. You need to do this better. So this is us paying for services, and and for this purposes of segregating money between these two pots, if it's because of a court order, it would sit there. So let's say Cooper Jackson is settled, the court is happy with us. Then what would happen is that would then switch probably to a different pot in discretionary, non-discretionary, so long as we were still providing those services and those forensic patients would get served. So it's not as though the federal government has said, hey, Louisiana, you owe the federal government $1.3 billion. It's the federal government has said, you need to settle this. And by doing these settlements, then the state has some control because you don't get a special master and that takes over your program. Or you don't lose federal match on anything that involves federal fund that is a match program, because then we still have control and it's an allowable expense under Medicaid. So we want to avoid a court order to the degree that we can. We want to do settlements to the degree we can, so that way someone doesn't come in and tell us what to do. That kind of allows Louisiana or any state the option to negotiate and do what those policy leaders think are best, given the services we have, the access. And some of this you're going to have to build access because, we know that there are issues with mental health. This is, specialized mental health patients that have gotten themselves in trouble with the law for a variety of reasons and now need some very specialized mental health services.
Okay. I appreciate the explanation. I'm just choking on the number of commas that we're looking at. Okay. Thank you, Mr. Chairman.
Yeah. The size of a lot of your spend in LDH will probably be shocking just because of the size of it.
Okay. Senator Henry, you wanted to clarify something or ask something?
You mentioned there was going to be a $500 million surplus in state general fund.
In total funds.
Total fund, yeah,
That's projected.
I think you said state general fund.
Yes.
Everybody got like, wow.
So how much of that's going to be state general?
What's currently projected now, 329.5.
That's state general fund.
State general fund.
Mm-hmm. And we'll get, as we get closer to the end of the fiscal year, the number will, get better. But yeah, I mean, it's because when budget was built for FY 22, we only assumed the public health emergency for 2 quarters. It's now been extended through the end of the fiscal year.
So that's
with each
that's the
extension,
money we're talking about.
Yeah, you draw down more federal funds and you can expend less state funds. And I mean, so they'll have to, obviously the department will have to shake out all the other means of financing, see what the actual revenue collections are, because we can't have Medicaid, run a deficit. It's got to match every dollar appropriately. And each month they submit these to Budget Committee, and they're on the, the website of Comwarts to the committee, but they do have to update for us the projected expenditures and the projected means of financing for the Medicaid program. And that's the report that came out on February 21st.
Gotcha.
And
Okay.
then also, this is listed on the fiscal status statement, the second page, as items for action in some of the supplemental bills or the funds bill. It's listed on there as well, and it comes to Budget Committee as an FYI to committee that, hey, we know we're generating excess, we have excess state funds right now in the Medicaid program.
Gotcha. Okay, thank you.
That answered my questions.
Okay.
Okay, I think you answered Senator Fessie's question too on that. All right, I think we're you're finished with page 34?
Yes, sir.
Okay, I think we're gonna stop at this point if the secretary wants to come up a minute.
Good morning.
Good morning, and as I think was stated earlier, we're not gonna go through this whole block today, okay?
Okay.
I don't think it's fair to you, and I don't think it's fair to us. I think there's too many things up in the air with CMS, too many questions, and I think we're gonna have many meetings with Department of Health between now and we finish the budget. So I think during those times, we'll get most of these questions answered. But I'd like you to give us a 15, 20-minute overview of what you think right now.
Yeah, and so I know Heather has a lot of our detail in the presentation, but I do want to, one, thank y'all for the support that y'all have given over the last year. For the department, it has been a trying year, given COVID, the hurricanes, and everything else that's been thrown at us. I think the last time we were here in Senate Finance last year, we talked a little bit about the business plan, and Senator Henry, I think you brought this up in terms of what measures the department was going to have in place and our planning around it. And so I do want to thank the members of the committee, because I know I've called you all a number of times since the last session to talk through our planning process, the elements that we talked about during session, what we've heard from stakeholders, and then actually going through and developing that process. So this past November, we did release our annual business plan. And part of it is, one, so we could put pen to paper in terms of here's what we're going to be focused on over the next year. So everyone knew where we were, what we're going to stand for, and then looking at where we ended up at the end of the fiscal year. So we definitely will be back having those conversations with you all, likely in July, August timeframe, when we are able to wrap up the results of what we saw over the past fiscal year. So in that business plan, we have 4 different commitments that we outlined. One was looking at the overall well-being of the state, in terms of our access to services and the overall outcomes, and with the focus on prevention. And some of those areas you'll see where we talk about maternal health services, we look at our breastfeeding rates, we look at behavioral health services, we look at colorectal cancer screening. Just a reminder, this month is colorectal cancer awareness. And so if you fall into those categories and you have not had your colorectal cancer screening in the last 3 years, we encourage you to go forward and help us to improve our rates here in Louisiana. You all last year did do some funding around Mary Bird that will help us to access and increase those services across the state. So really, when we start looking at our business plan and our development, we took into account what we heard from you last session, incorporated some of those elements in there. The second piece that you'll see in the business plan is around our LDH culture, some of the recruitment, retention, and succession planning. And we talked a lot about succession planning. And I think when I got on the road and went to a couple of the areas, we talked about the turnover that we see in the department. How do we put in place succession planning so when someone who's been in the department for 20, 30 years, they decide to retire or they take another role, that we don't have a gap in that knowledge in the department. So creating a succession planning program. The third element that we had in the department is around our relationships and partnerships and building some of the community support. We've done a lot of that around COVID, but we need to extend that across all elements in the department. So you'll see in the budget also some of the work we want to do with some of the universities of drawing down some federal funding. So when we have an alignment with any of our public universities that are working on a project, how do we partner with them if they have state funds to do that work? How do we partner with them on that particular project and for our state to draw down some federal funds? This is something you'll see other states do. So how do we utilize our resources and the support we have a little bit differently here in our state? And then the fourth element of the business plan is around compliance, transparency. And that's a lot of work we've done with this committee in terms of fraud, program integrity, as well as our hospital financing, some of those programs that we'll get into as we move further along in that process. So those are the four main elements. You'll find in there 17 initiatives, 42 goals. And again, our intent is to, at the end of the fiscal year, to summarize where we stand on that. In each of the business plan elements, you'll see we talk about where we started and what's our goal. And some of those we'll see where we stand on the national average. And then we want to report out where do we fall in our state. In the event that we don't meet those particular goals, and there's a couple in there that I think we're going to try our best, but it's likely we won't, particularly around some of our turnover rates in the department. We all see across the nation in terms of the employment struggles that we're having. So the department is no different, but we still have to put the work in to try to improve those rates. And then we want to report out where do we stand. And if we didn't meet it, then we need to be able to come back to you all and to the public to explain why we didn't meet it, what are the elements that need to change, or if we went a different direction, why do we go that different direction? What did we learn in our process that made us go in a different direction? So that's the work that we've been doing over this past year. Again, we released it in November, but the time frame runs from July to June. And I think regardless of who sits in the secretary's seat, this is something that the department and you all can hold the department to on an annual basis. It's not just us internally setting these goals, but it's us working with the body as well as stakeholders to be able to do this. So that's what we've been working on, Senator White. I think you'll see several of the elements that Heather is going to touch upon that are continuations from last year. Senator Milligan, you just asked about some of the services and behavioral health and some of the lawsuits. I will say when we enter into those settlements, it is I don't want to say a savings for the state, but when you look at in terms of if we actually entered into the litigation and the court order, it would be much more costly for the state for something that we had not been doing. And so thankfully you all funded a large portion of crisis services last year. If you remember, you funded 3 services that we're currently in the process of going through RFIs. Out of the 10 regions in our state, we have 7 providers that have been selected, and those for 7 regions. We're continuing to work on the other 3 regions, and we want those to go live for 7 of them by May. As soon as we get the other regions selected, then we'll be able to move through that process. But you all developed and started beginning that crisis continuum of services, which helps us to meet the needs of that particular settlement. Also in the budget, you'll see we're asking for an additional crisis services. This will be a short-term stay, kind of an inpatient, but a 1 to 5 day stay that you'll see that we're asking to be able to have this service in every region. What we want to do is to make sure we have true behavioral health continuum of care in every region of our state. The other piece that you'll see in there is related to behavioral health is an increase in terms of beds across our state. And so as Heather mentioned, we do see many of the services that we provide at our facilities, we are not meeting the needs. We do have pent-up demand. Our wait lists have increased, and the amount of days that someone takes to actually enter into the facility when that need and assessment is done has increased tremendously, and we're beyond the 15 days. And so we've had conversations with the disability rights and some of those folks who have been involved with the settlement. And so you'll see in this budget request an increase. It's about 224 beds. They fall into different categories, but this would be us contracting these services in the private market. So when you're talking about civil intermediate beds, inpatient beds, and then transitional beds for both Central Hospital as well as Elms forensic beds. And so these are some of the things that you'll see that we're asking you to help continue those behavioral health services so we can maintain compliance in those settlements so we don't have to go further into litigation, which would be much more costly for our state. The other thing I'll highlight in the budget, I'll highlight 2 more things if you don't mind, sir. The other piece I'll highlight is around the work we're doing in terms of direct service workers. So last year, this body did some work around direct service workers and increasing the provider rates, but really making sure that those provider rates went, the majority of that funding, to direct service workers, particularly around individuals who are accessing developmental disabilities on the waiver side. And you all did it through the Now Fund. And that was limited to those individuals receiving services through DD waivers. You asked us to go back and make sure, as we were looking at our budget and working with stakeholders, to do that for other elements as well. And so in the budget request, you'll see that for the aging population on the waiver side, because now we have a disparity between those two populations. And lots of times you have the same provider and the same individual who's providing those services. And we already had a disparity to begin with between aging and the DD services. You also see where we did the same direct service increase for the ICFDDs as well. One for the nursing homes, and then again for our transitional forensic beds as well. So you'll see that element in there. Again, I know many of you have heard from providers in those communities in terms of the struggles that they're facing with staffing. Again, you've heard it across the nation in terms of the employment issues. These providers serve our most vulnerable population, and they are struggling in terms of their ratios and just getting staff. Even when they've moved their administrative staff to provide services, they're still not able to maintain the minimum standards in terms of providing care. The last piece that I'll highlight is some work that you all did last year, and you funded around our Medicaid Management Information System and some of the work that CMS is requiring that states move to modularity. Our state is behind other states in terms of moving in that direction. Last year, you funded a big portion. This year, we have an even larger portion that we're asking you to fund in terms of, I think it's 6 modules, true modules, and then a couple of integrator services and support services that are in there. Right now, that funding for our state will be at 90-10 match. So I think the total is about $109 million, and I know Heather has in her presentation. And then the state fund would be 11.6, so my number's a little bit off. But again, we have to capitalize on that before CMS starts to come in to do those reviews of us not moving in that direction around modularity. And the important thing around modularity is it does reduce the risk of the state of doing that large MMIS procurement. Because usually when you do those, by the time you procure it, you select a vendor and you move forward, you already pretty much are outdated in terms of what's on the market. So by breaking them to these components, we have a little bit more success in terms of doing those contracts, procuring the services, and then as you need to make adjustment, you're making an adjustment on that particular frame of it. So those are some of just the key things that I wanted to highlight that I know Heather will go over in her presentation, but some of our focus for over the next year. And I didn't introduce myself, but I'm Courtney Phillips, the Secretary of LDH.
I didn't recognize you with that mask on. I think you and Heather got in a speed talking contest.
We're from the same
I
tribe.
can't hear
so
that fast.
We're both from Acadiana,
we can't help it.
yeah.
40-something years, we've been working on it, but just can't change it.
All right, Senator Boudreaux, you had a question?
Yes, thank you, Mr. Chairman, and Dr. Phillips, thanks to you and your team during some difficult times, the leadership and the outreach. Couple of items. I know we got some RFPs that are out. If you can touch on where some of those are, I know they've been a long time coming, but just to see where they are when you anticipate those announcements. And then I'd like to ask, which, with gas where it is today, some of our providers, of course, that fall under the MCO contracts that are providing that quality service for us. The gas thing's not going to go away today or tomorrow or next month, but what options do we have to factor in some relief for these individuals that are providing those services for us? And I'm asking from this level because they don't know where to go, and I don't know if there's anything possible for us to do to continue that service. We talk about the inability to secure that workforce, but they're out there contractually doing things, and I know we're in, and I'm concerned about the long haul. If we don't look at how we can adjust some of those now, we're going to lose more of those providers. So that, and then on the mental health component of what we're where we are. And I failed to, when the plan was released in November, and look, we've been on more conference calls, you and the team at LDH. If you're not engaged or if you're not included, it's because you don't want to be. I mean, there's a call or two every week on information, and I appreciate that. I really do, and I try to stay on as many of them as possible. So you all have done a yeoman's job of trying to connect us. It's complicated. This whole, anything we talk about in LDH is complicated, as you said. Heather pointed out in her presentation, just the sheer factor of it encapsulates so much and in terms of dollars, that it brings that attention, not understanding, the federal match, not understanding how we draw down, and some of the stipulations that come with that money. But it's easy to attack because it's such a large target. So yeah, if you can hit on those, and conclude with where are we with mental health and some of the other things in the plan that we're going to try to get done. I mentioned it earlier this week about our veterans and the desire to do more in that area. So I'll stop right there and just ask you to respond to some of those for me.
Thank you, Senator Boudreaux. And I'll reverse order and let Steve in with the RFP just because we're in protest and blackout period for those. So I'll let him respond to that if you don't mind.
Okay.
So just in terms of behavioral health services, I think the commitment that this committee and this body has made over the last year is setting us on the right track. Again, we do have a request in this current budget because what we did last year was just the beginning of it. And so over time, I think you all have stressed the importance in our state of investing in behavioral health and making sure that we don't just have services centralized in a particular area of the state. And our behavioral health team has been working to make sure that we're able to put it in every single region. So folks don't have to travel somewhere when there's a needed service. That's going to take time to build that capacity. As a nation, we've focused on physical health services. We haven't focused on behavioral health. And in the last decade or so, we are catching up. And so that's some work that we're going to have to do. But I do think the commitment that you all have made the last couple of years, and if we move forward in that commitment this year, then we're headed in the right track for that. I think in terms of...
Can I just stop and say, and I appreciate and I recognize that one of the things that I would hate, and that's where we've been as a state. We've started stuff, and as you said earlier, and I appreciate you bringing it out. It doesn't matter who sits in the secretary's chair. There are some things that we should do and must do, and we owe it to the people of the state to do. And when it comes to that behavioral health model that you're talking about, it shouldn't be every 4 years hitting the reset button and seeing where we go. There has to be a continuum of care. And what I liked about your plan that you rolled out, the business plan, that as you said, we should have that we should be able to review that every year and see, what progress we've made. And my point, and I want to let you talk. My point is, I want to see as much as possible where depending it is regardless of who sits up here or who sits in your chair, that these programs continue, and that it's not on whose idea or who's the author or any of those things, because on the other side, that population continues to grow, and we actually pay for more on the back end than we would on the front end. So I want to see more of that.
And that's why we did the plan. And so again, it's not my plan, it's not Karen's plan, it's not Steve's plan, it is the state's plan. And so that's why it factors in what we've heard from the body, what we've heard from stakeholders, from families, our own families. And so it's important that on an ongoing basis, we do that review. We share with you all what we find, where we stand in comparison to other states, as well as what's the gaps that we see. We don't always have to be where another state are. Sometimes we want to be better than those other states. And so how do we get there? I think these investments do that. I'll mention one thing about behavioral health and shift into non-emergency transportation, which I think you were asking about with the gas. One thing that we are doing around behavioral health services as well, outside what I've already mentioned, the federal government did a home and community-based plan, enhanced federal funding where states could apply for. And so we in Louisiana did apply for that plan. And as you and I have talked before, the importance of not just creating services, but having entities and individuals who can provide those services. So that's some work we have to do in our state as well. So we can create these services, but we also know we have to have provider organizations and have qualified individuals who can provide these services, but they want to stay in that particular field, in that industry. So in this home and community-based service enhanced funding plan, we requested in that to get some funding to support and maintain recruitment and retention for our behavioral health providers for those particular individuals, because we can't do what we're talking about doing unless we have the people who can provide those services. So you will see that in that. Also in that same plan, and all the elements haven't been approved yet, we're working back and forth with CMS on this, is related to non-emergency transportation, and the exact same thing, some additional funding to support those providers and the work that they've done throughout COVID to be able to support the increased costs that they have seen and are seeing. So that's currently pending in that plan. We have not received approval yet. We're currently going back and forth with CMS, but we are definitely pushing because our folks have that need, and I think we can make the case to justify that. Oh, there you are.
Senator Boudreaux, Steve Russo, Executive Council, Louisiana Department of Health. We've got 4 major RFPs out right now. Of course, the big one is the MCO RFP. We selected 5 providers, LHCC, Aetna, Healthy Blue, AmeriHealth Caritas, and then, of course, the new entrant would be Humana. That left one of the incumbents out, United. United has filed a protest. Our brief in the protest is due to the Chief Procurement Officer over at DOA this Friday, March 11th. The potential winners have asked for this morning and got an extension of March 18th to file their briefs. And then, of course, United has until March 25th to file their reply brief. And so a decision is set on that for April 8th. The Chief Procurement Officer over at DOA, though, did say that they, of course, reserve the right to slide that date further back if necessary. The other 3 major ones that we have out, of course, is a selection of a single non-emergency medical transportation broker, a selection of a single pharmacy benefits manager.
Can you tell me where those are in the process?
We are currently we're currently awaiting concurrence on non-EMT over at state procurement. Pharmacy benefits manager, I think, is in still. The proposals on those are due this month. And then, of course, the final one that we have, major one, is electronic visit and verification. That's going to help us with some fraud, waste, and abuse. And then, of course, for some accountability of home and community-based providers. So that is in the early stages as well.
So with the exception of one that's being challenged now, the other 3, we're still the window hasn't closed. I mean, we haven't reviewed all of the proposals and everything. Is that
No. For non-EMT, we have.
okay?
For EV and V, for PBM, those proposals are due later on. But Ruth can have the specific dates. Yes. For non-EMT, we have selected, and so what I mean by it being over at OSP for concurrence, we have made the selection.
You made your
Sent it to
recommendation. They are
exactly.
vetting it or due diligence that's
Yes,
left,
sir.
and then
Exactly. Yes,
any
sir.
time frame on how. I mean, I should ask them, huh?
Yeah, I hate to say that, but yeah, you should ask
All right,
them.
I will. If they're listening, I'm asking them now. And my phone's ringing. I think they're calling right now. No, that's good. That's good.
And we can check in to see if they give us
Yeah.
an estimated time for you,
Look,
Senator Boudreaux.
Look, the only reason why I'm asking is because I know all of these will enhance the plan.
Yeah.
And there's a lot of angst out there as to even going with the single provider, what impact that'll have in the whole 9 yards. So I'm, just like you all, very anxiously awaiting the implementation of these so that we can see some enhanced benefits. So, and we've had the discussion. We have to get people that, they're in the field. We have to get, boots on the ground. You can't come into certain communities with people and think you're going to get the positive outcomes if they don't know where the roads and the streets are. So we have reached out and we've gotten those people, but Secretary, I've shared with you, my concern is if we turn the light off, the roaches come back out. We got to keep the lights on and we got to keep connected. So whatever assistance we can get in those areas, because while, the main emphasis was COVID, we're a couple months away from hurricane season. We still dealing with some things from the last 2 years before COVID. So thank you for that update. And just we'll stay tuned. But it's health in hospitals and this whole department. Is just until it's your mama or it's your sister. I mean, you don't think it impacts you, but it does. It does. And while, like I said, when you get to this section of the budget, a little different than education, but just as more important to me, we got to have long-term planning. I mean, when the decision was made to leave the charity hospital system, everybody thought that was the next coming, and it hasn't been. And we're still trying to put the genie back in the bottle. We're still trying to provide that health care and those opportunities to some displaced communities and populations throughout this state. So collectively, we have to get there. So that's it for now. As the chairman said, we have a lot of work to do. And I want to thank you and your team again for keeping us engaged in the process.
Thank you, Senator Bidger.
Senator Abraham?
Hey, Mr. Chairman. I just wanted to make sure I heard properly. The Medicaid Management Information System, did you say you budgeted $109 million for that?
We have a pending budget request, and I think once Heather gets to the Medicaid Vendor Administration Program, you'll see some of our requests in there, but we're requesting for funding for 4 additional modules, some work on the integrator, as well as some support services. So I think it's 109, 111.
It's 109, but I want to point out that this is at 90-10.
Yeah, with this match.
Right,
Yeah,
so the federal
state
government's
match.
paying the lion's share.
And then my last question, just to kind of drill down, I know I'm really drilling down, but this is my area. My understanding is the Imperial Calcasieu Human Services Authority needed some more TOs because they're taking more services in-house, and y'all were planning on increasing their TOs, but it doesn't show that on this budget. So just want to make sure that is going to occur, the budget authority for them.
I'm not aware of it, but I will definitely look into it for you before we get back here. And, I mean, Imperial's here, but.
Yeah, they're here, and they were asking me about it, so I just want to make sure we cleared that up. Make sure we're on the same page.
We haven't gotten to the districts yet.
Okay.
Okay, you're going to continue with it? Okay.
If you want to add.
Yeah, so I think, Senator Abraham, we're going to have to do some work on it. It looks like it may have been in the initial request and it didn't make it all the way through. So we'll have to have some follow-up conversations on it. It's not in the current budget, so no.
okay.
The recommended budget.
Yes.
Okay, all right, just keep me posted on that.
Okay,
All right, thank you.
you're welcome.
All right. I see no more questions. I think there's, like I said, you and I talk early and often, sometimes late at night at 10 o'clock. You call me. We'll keep working the process. It's such a huge block for us to deal with and try to absorb. I feel like this committee's put a lot of work in it. This will be our 3rd year, and I tell everybody I know more about healthcare than I ever cared to, and it's ever changing. And but with that, I think we're going to meet. We may meet next Tuesday morning when we come in. I think we may have a couple of hours there. We may catch a couple of blocks then whenever we can until we start, because we start the session next week. But with that, I see no more questions.
Chairman, can I just say one thing? I do want to thank Heather and Sherry, along with the full committee, and our team as well, for all the work that they've put into, one, just preparing for the budget process, but just throughout the year. Y'all have been extremely accessible to the department, so I do appreciate it, somebody coming back in the midst of COVID and having to rely on y'all, so I do appreciate y'all's support. I do want to point out one thing. I know we've done a lot of work with this body on drinking water, the revolving loan fund. I think we're going to have some ongoing conversation with you all as it relates to the Infrastructure and Investment Act. That wasn't available when we developed the budget, so I'm sure you're going to hear this from several different agencies. Depending on what the state wants to apply for that Investment Infrastructure Act, state match will be needed. And so we want to make sure that we're working with this committee and the House side on that piece of it. We're not ready yet. The guidance just came out for our department yesterday, but I just wanted to give you a heads up. If you hear about it, this is where, we will engage with you all going forward on that.
Yeah, and I had a conversation with Z yesterday evening for a couple of hours, and he and I are going to get together on some of this, and we'll be talking about it too, so we can try to work with the House.
Thank you, sir.
All right. I see no more questions. We're adjourned.